Hello and good evening. Can you hear my voice, please?
Yes, we can.
Dr. Lukman, can you hear my voice, please?
We can hear you.
Oh, excellent. So that's it then. I think we can start and others will join us. I'm going to share my screen with you. Let me start by welcoming you. Good evening, everyone. And I want to sincerely tender unreserved apologies for the period that this lecture was slated for, and I was not available. In the first instance, it was due to another assignment by Medical Rehabilitation Therapist Board. But the second instance, I was away in Ilorin a day before the protest. I hope to return back to base on Friday so that I can commence the lecture on Saturday. But unfortunately, the assignment I'm supposed to do in Ilorin was not done because of the protest. So I have to forfeit the day because I couldn't even come back to Kano. So I apologize. It's not in my character to come late for any event, and it's not in my character to postpone events unduly. So I'm really sorry. We'll always find a way to compensate for the lost time. So having said that, I'm going to start off because of time. The approach we're going to use will be to look at the anatomy, then we'll look at the pathophysiology. We have an overview of treatment method, and we dwelled richly on manual therapy. As many of you might know that I'm a manual therapist, so that is my area. So majority of the explanation on the treatment protocol that I'll be giving will be based on exercises and manual therapy. Just to let you know again that I've also spoken with the Ray physio to say that because of the protest and curfew in Kano, it's not possible for me to go to their studio and so that I'll be carrying out the technique and you'll be watching it live. But I have said to the coordinator that at no other expenses, I will be willing to go to Ray Physio Studio and demonstrate all the techniques I'm going to talk about tonight at any designated day that will be so allowed. So those are my preambles. I want to welcome you again and thank you for your patience. And we thank God all together because we can still be here to discuss what we have to discuss. So my respected colleagues, I'm going to start off this presentation on the lumbar spine, all right? And the way we're going to deal with it will be to start from the functional anatomy of the lumbar region. Please don't take it for granted that you have been taught the anatomy. Let us go through it together. Because in manual therapy, anatomy is very important. And you know, when physiotherapy is discussing anatomy with physiotherapists, there'll be a difference compared to when anatomist is teaching physiotherapy to a physiotherapist. So please let us not just wave it to the side. Let us all be together on the same page. So in today's lecture, we have a lesson outline. At the end of this section, this is just the first section. At the end of this section, we'll be able to identify, everyone here should be able to identify the region of spinal column, should be able to describe and observe the movement of the spinal column, you should be able to make a surface mark and palpate common bony landmark of the spinal column, identify major muscles of the spine, use appropriate anatomical terminology, and even more. And even more, we should be able to know even more than that. Okay. All right. Now, the next slide will be on the general function of the lumbosacral spine before we go into the anatomy. General function of the lumbosacral spine. So what we do know is that the lumbosacral spine is in the middle, isn't it? You can see it in the middle here. if you follow my cursor. So it's serving the upper region, it's as well as serving the lower region. So if we think of it that way, explaining its function would not be so much difficult to us. It supports the thoracic cage. It provides attachment for muscles of the pelvic girdle. It anchors the powerful trunk muscles. It protects the spinal cord. That's the lumbar or lobosacral segments of the spine. And it provides flexibility of movements. I'm sure we are all conversant with this. Now, the approach we are going to take to study the anatomy will be to do the osteology. We're going to look at the bones and we'll be saying the relevant points to our practice. We look at the ligaments, we look at the muscles, we look at the intervertebral disc, and we'll be explaining the very relevant and salient points to our practice while we're doing this. Okay. Right. So at this moment, we want to look at the lumbar vertebrae. Let's start off with lumbar vertebrae. Now, I'm sure we are all familiar with this, that lumbar spine comprises of 5 vertebrae, and each vertebrae consists of a large cylindrical vertebral anterior body, all right, and with a bony ring and a neural arch posteriorly. These are the anterior body. This is the anterior body here, and these are the arches, these little pedicels and lamina, and then that transform into these processes. We are going to look at each one of them in greater detail. But just like we have been told in case of cervical spine, in case of anatomy of cervical spine, I'm sure we have been instructed there's a typical vertebrae, there is atypical vertebrae. The same thing applies in lumbar. The first 4 lumbar vertebrae, they are very similar in structure, so we call them typical vertebrae. The 5th lumbar vertebrae is a bit different because this 5th lumbar vertebrae is the one that articulates with the 1st sacrum. So it has a lot of features that are similar to sacral vertebrae. So the 5th lumbar vertebrae is particularly called atypical lumbar vertebrae, whereas the first 4 are referred to as typical vertebrae. Okay, so just like we have in the cervical, we also have in the lumbar typical and atypical vertebrae. All right, sir. So after that, we're going to look at the typical vertebrae. What are the features we're going to find on typical vertebrae, and what are the relevance of this feature to our own practice? We'll start off with that. Now, a typical vertebrae, like we explained earlier on, is going to have a body. That's the cylindrical rounded part at the bottom of this slide. So it has a body. The body of a lumbar vertebrae is very massive. And when you look at the transverse diameter and you compare it with the anterior-posterior diameter, you're going to find out that the transverse diameter is greater than the anterior-posterior diameter. That's how we identify lumbar vertebrae. All right. Beside that, it has projections. Can you see the little projections from the body? From this point to this point. That is called the pedicels. And the pedicel continue in the upper part as the lamina. And the lamina projects eventually into the spinous process. Now, those landmarks are very important to us, especially those of us that practice manual therapy, because they provide the landmark for us to apply the right type of treatment. So there's a vertebral body, there is a pedicels taken off from the vertebral body, and it join up to form a lamina, and the lamina project to form the spinal cord. The pedicels is very short and thick. The lamina is also short, but it's broader than the pedicel. All right? You soon see the relevance of all these points very soon. All right? So we are still on the body. We've just discussed the body and the arches of the vertebrae. The pedicels and the lamina make up the arches of the vertebrae. All right? Now, we want to talk about the joints. No. Before we go to the joints in the vertebrae, let us look at yet some other salient parts on the body of the vertebrae. You will agree with me that this is the lumbar vertebrae. This is the body of the lumbar vertebrae here that we have seen in the other diagram. All right. And this is the pedicel. This is the short pedicels. You see those two projections above, they are the superior articular facets that this vertebrae we use to articulate with the vertebrae above. And then we have the inferior articulating facets here that the vertebrae we use to articulate with the vertebrae below. And very close to the transverse process, we have a mammillary process, which also serves as a point of attachment for the multifidus muscles. Okay, so those are other features that we have to take note in the body of the vertebrae. You see the two superior facets, superior articulating facet, and you see the inferior articulating facet. All right, then we can identify the mammillary facet on the posterior aspect of the transverse process. Can you see the transverse process? And you can see the mammillary process. Before, I used to think that there are 7 processes. That's the transverse process, spinous process, that makes it 2. Then, well, 2 transverse process and 1 spinous process, that is 3. Then 2 superior articulating facet and 2 inferior articulating facet. But now, there are more than 7. Lumbar vertebrae do actually have a mammillary process, very close to the transverse process. And the purpose of that is to serve as a point of attachment for multifidus muscles. Okay? Right. Now, I want to talk briefly about the transverse process. The transverse process is clearly shown in this diagram. All right? You know, it's one of from the pedicel. Can you see the pedicels more clearly here? The pedicel projects to form the lamina. It also projects to form the transverse process. Can you see the part of the transverse process labeled as an accessory process? That is actually illustrating the mammillary process where multifidus is attached. What is the purpose of transverse process? It's also for muscle attachment, okay? For muscle and ligament attachment. That's the purpose of the transverse process. We can also see the spinous process in this diagram. So you see the pedicel wash the lamina, and the 2 lamina project to form the transverse process, which project vertically in a superior manner in this diagram. And what is the purpose again? It is all mainly for the attachment of muscles and ligaments. All right. So I'll go on to the next part of the vertebral body, which is the vertebral foramen. Right. The vertebral foramen in the lumbar spine is triangular in shape. And you can see in this diagram, it is colored green. That's the vertebral foramen. And you know the purpose of vertebral foramen is to house the spinal cord. All right. Very close to the vertebral foramen, we have the transverse foramen. What is also called in some book as vertebraterial foramen or transverse foramen. So why the spinal cord passes through the vertebral foramen? The spinal artery, the spinal vein, and vertebral nerves, the nerve roots, they pass through the transverse foramen. Okay? So how do we recognize the vertebral foramen of the lumbar spine? It is broad and it is triangular in shape. And that's where spinal cord passes through. It is right inside transverse foramen that spinal nerve passes through. So when we say a patient is having spinal stenosis, it could be due to the narrowing of this foramen. If there's narrowing of vertebral foramen, it will give birth to central spinal stenosis. And if there's narrowing of the transverse foramen, it will give rise to peripheral spinal stenosis. Okay? So that is about the vertebral foramen. The next one we would like to talk about is the atypical vertebrae. We have looked at the salient features in typical vertebrae. And you remember I said the atypical vertebrae is the is the fifth lumbar vertebrae. So what are the things that make the fifth lumbar vertebrae atypical? All right, the points are listed here. When you look at the atypical, when you look at the fifth lumbar vertebrae itself, the superior part of the lumbar vertebrae is greater than the inferior part. The superior part is greater than the inferior part. So it tapers downward. You are still going to see this one in a better diagram very shortly. The same thing applies to the disc. The disc between L5 and X1, it is wider superiorly and narrower inferiorly. So the shape is not a perfect oval. It is like a cone. All right. That's one of the differences between L5 and the rest of the lumbar vertebrae. When you look at the spinous process of L5, it is also thick, but it is less in size than other spinous vertebrae. You know, you remember I said that why L5 is L5, while it is different because it's the closer to the sacra and is taking the features of sacra, some of the features of sacra vertebrae. So the spinous process of L5 is actually smaller than other spinous process in the lumbar vertebrae. However, the transverse process of L5 is very large than other, and it is directed superiorly and posteriorly. I'm sure you see it in a better form in subsequent diagram, like this one that I'm going to project. So we are still talking about atypical lumbar vertebrae, which is the L5. If you look at this diagram and you go to the L5 vertebrae, can you see the L5 vertebrae on that diagram? You will actually agree with me that the superior part of that lumbar vertebrae is broader than the inferior parts. And these are part of the reason why it is atypical. The same thing applies to the intervertebral disc between L5 and X1. You can see that the maybe it's not very obvious in this drawn diagram, but the spinous process of L5 is actually smaller than the spinous process of the other. All right. So this is the fifth lumbar vertebrae, which is being referred to as atypical lumbar vertebrae. Now, the next feature I would like to talk about in the osteology of the lumbar vertebrae is the feature called lumbosacral angle. What is lumbosacral angle? What are the normal value of lumbosacral angle? What could be the implication of having an exaggerated lumbosacral angle? Lumbosacral angle is the angle between L5 and sacral vertebrae, between L5 and the body of the sacrum. Take note, I didn't say it's the angle between L5 and X1, but the angle formed by L5 and the rest of the body of the sacrum. Do you understand? That is lumbosacral angle. Now, if you look at the diagram here, you see two lines in blue ink. One is drawn through the inferior part of L5, and the other one is drawn perpendicularly through the body of the sacrum, and you can see the angle in theta there. So the angle between these two lines is what is referred to as lumbosacral angle. The normal value of lumbosacral angle in any individual should be about 35 to 40 degrees centigrade. It should be about 35 to 40 degrees centigrade. Now, if the lumbosacral angle is unduly exaggerated, it produces hyperlordosis. All right? So it's going to stretch all the muscles in the anterior part of the spine, and it will weaken them. It can even predispose to slip disc. If the lumbosacral angle is more than 40 degrees, it can predispose to the shifting of the intervertebral disc between L5 and X1. It can also predispose to listhesis, dislocation of L5 over X1. So that is just to mention that about the lumbosacral angle. I'm sure everything I'm saying is also on my slide. And these slides are yours after this presentation. So you can take your time to go over them again. And you have the audio being recorded, so you can try and, do a quick revision with them at any point that is so desired. All right. So this is still talking about lumbosacral angle. I've said the normal value is about 30 to 40. But if the lumbosacral angle is exaggerated, it can predispose to intervertebral disc herniation, and it can also predispose to spondylolisthesis. So when you have the X-ray or MRI from your patient that is having lumbar or lower back complaint and you're looking at it, you also have to pay attention to the lumbosacral angle. And if it is found to be exaggerated, then you'll have to commence postural re-education exercises. All right, so that's about the lumbosacral angle and the bone. Now we'd like to talk about the intervertebral disc. The intervertebral disc. We're going to spend some time to discuss the anatomy of the intervertebral disc. All right, just like we rightly know that the intervertebral disc is made up of three major parts, isn't it? The intervertebral disc is made up of three major parts, not two, like we usually have been told. Yes, I'm sure all of us know that there is inner nucleus pulposus, as you can see from the diagram, and there is outer annulus fibrosus, isn't it? But the part of the intervertebral disc that make contact with the vertebrae itself is the third part. And that is what is known as the end plates. I'm sure I'm going to show you in one of the diagrams before we finish this anatomy section. So the intervertebral disc is made up of three parts: the inner nucleus pulposus, the outer annulus fibrosus, and the end plate. All right. Now, let us consider the anatomy. The intervertebral disc of the lumbar region, particularly, how is it different from the intervertebral disc of other regions? The intervertebral disc of the lumbar region is different because the annulus fibrosus, can you see the annulus fibrosus in this diagram? You see that annulus fibrosus in this diagram are arranged in sheets called lamellae, and the lamella are not the same. One row of lamella is arranged at an angle to another row of lamella. So it's not just the lamellae arranged in cylindrical pattern. If one row is going at a particular angle, the next row will go at 120 degrees. The next row will go at 120 degrees. So the lamellae of the intervertebral disc are arranged at different angles and different orientations. Different angles and different orientations. If you look at the diagram here, you see where theta is marked. Can you see two red arrows where theta are marked? So you see the orientation of one lamellae to another lamellae. So the actual angle between the two lamellae is 120 degrees. And this orientation of the annulus fibrosus in the lumbar vertebrae is so desired so that it will be able to act as shock absorber, so that it will be able to contain the nucleus pulposus and it will be able to withstand a lot of stress and strain. Okay? So that to be able to withstand a lot of stress and strain. All right, I'm sure you still see what I'm saying in my next diagram. This is where we are. I'm talking about what make lumbar vertebrae, intervertebral is different from the rest. My expectation is that when we come to lecture like this, we should have a little more knowledge than people that just read on the net or people that we had a degree with. So I'm going to be giving you some extra information right from the anatomy to the end of the presentation. So the collagen fibers in the annulus fibrosus of the IVD in the lumbar spine, they are arranged at angle to one another. That angle is 120 degrees. And the advantage of that arrangement is to be able to resist tensile forces, to be able to resist stress and strain due to the weight of the body. Okay? Now, we're still going to the intervertebral disc. we have been able to state the reason and how the lumbar vertebrae IVD is different from the other. Generally, the intervertebral disc, like I told you earlier on, is made up of three parts: the inner nucleus pulposus, the outer annulus fibrosus, and the cartilaginous end plate. If you look at that diagram and you see CEP, CEP is referring to the third part, which is the cartilaginous end plate. Now, when you consider the anatomy of these three structures again, you will be able to understand how they function, and then you will also be able to understand changes that come upon them at old age. All right? Generally, when we remove the intervertebral disc from every normal human being, the height of that person should be reduced by 25%. So that is saying that the IVD generally contributes about 25% to the height of a normal human being. All right? Okay, so we're going to look at the components of the disc one after the other. Let's come back here. Let's come back here for a moment. All right, so we see the nucleus pulposus, the inner nucleus pulposus, the outer annulus fibrosus, and the cartilaginous end plates. How are they different anatomically? If you look at that diagram, you will be able to see that the nucleus pulposus is mainly made up of water and proteoglycans. 60 to 70% of nucleus pulposus is water and proteoglycans. It has very few amount of fibers. But if you look at the annulus fibrosus, the reverse is the case. The annulus fibrosus, 60 to 70% of it is made up of what? Of collagen fibers. And only 30% is proteoglycans and water. We're going to see the reason for all this very shortly. Okay? One slide should lead us to another slide for proper understanding. Okay? I'm sorry, I'm just trying to arrange my slide. Right, this is where we are now. The intervertebral disc being made up of what? Again, nucleus pulposus, that is number 1. Annulus fibrosus, that is labeled number 2. And cartilaginous end plate, that is number 3. That's the part of the disc that made contact with the bone. And of course, the 4 will be the bone in between which the intervertebral disc is resting. All right? Now, I want us to pay attention to nucleus pulposus. What about nucleus pulposus? Look at the diagram. And here I said 60 to 80% of nucleus pulposus is water. The remaining percentage refers to combination of protein and carbohydrate components called proteoglycans. And the remaining 20% is due to collagen and elastin fibers. And it is so like that so that I'll be able to bear the compressive load due to the weight of the body. All right? We're going to see a different arrangement for the annulus fibrosus. A different arrangement for the annulus fibrosus. For annulus fibrosus, it is very low in water and proteoglycans, but it is very high in collagen and elastin fiber. Why is it like that? So that when the nucleus, with aging, the nucleus pulposus to get degenerated, loses the water, and it will be pushing on the annulus fibrosus. So the annulus fibrosus really have to be very tight and strong to be able to withstand the pushing force of the nucleus pulposus. So that is why the annulus is mainly fiber and less of water. But the nucleus is mainly water and less of fiber because it's the one that will transmit the body weight from the axial skeleton down to the rest part of the body. Okay? Then we move on to, we're still on this disc issue. So if you see this diagram here on slide number 22, it's illustrating the properties of annulus fibrosus in diagrammatic form. So you can see the axial load, the load or the weight due to the weight of the body, that is represented in green. And that is bearing directly on the nucleus pulposus. Then you see, as nucleus pulposus is losing its content, it will be pushing on the annulus fibrosus. And that is represented by the horizontally directed red line. And that is why the annulus fibrosus has to be like 62% collagen and elastin fiber and less of water, so that it will be able to withstand the push or the stress created by the nucleus pulposus due to aging or relevant pathology. All right? Again, the end plate, we just have to talk about the end plate. The end plate is part of the IVD that made contact with the bone. And it also has a function it's performing. It's from the end plate that nutrients get into the intervertebral disc. The intervertebral disc is almost avascular. It is almost aneural. That is, it doesn't have blood supply and it is partially innervated. So where will it get its nutrient from? All the blood vessels that innervate the IVD end inside the end plate. So it is right from the end plate that nutrient diffuse onto the rest of the intervertebral disc. Okay? So we go on to slide number 24, beg your pardon. Now we're going to talk about the intervertebral disc in general. We have looked at the component part, that is the nucleus pulposus. We have looked at annulus fibrosus. By now, we know the difference in the constituent and why it has to be like that. We've talked about the cartilaginous end plates. But what are the general functions of the intervertebral disc? Number one, as a shock absorbers, all right? Transmitter of compressive load. Thanks nucleus pulposus for that. And basically, the intervertebral disc allow flexibility with spinal movements. As you can see in that diagram, that sort of movement wouldn't have been able to take place if intervertebral disc is not between L5 and X1. All right, so it's just a way of showing that the intervertebral disc is what allows for flexibility of movements, compressive load bearing, and acting as a shock absorber to transmit the weight from the axial part to the rest part of our body. Now, we're not going to stop the anatomy until we discuss the intervertebral disc blood supply. This is very important to us so that when a disc injury is reported and we see one patient making quick recovery, we see the other one slowing down in the rate of recovery, it could be traced to the depth of the injury. Because as far as blood supply is concerned, the intervertebral discs are avascular. They don't have blood supply. All the blood supply that gets into the disc terminates inside the cartilaginous end plates. So it's right from the end plate that nutrients will diffuse into the nucleus pulposus and annulus fibrosus. And the nucleus pulposus being more porous than annulus fibrosus allowed more nutrients to be transferred into nucleus pulposus than annulus fibrosus. Okay? I want to quickly look at the nerve supply of the intervertebral disc as well. All right? Now, the disc is quite an unusual structure because it receives innervation. Different parts of the disc are innervated by different nerves. Different parts of the disc are innervated by different nerves. The anterior aspect of the disc is innervated by the sympathetic branch or sympathetic trunk or sympathetic ganglion, as you can see in that diagram. You know, this is the, let me minimize the diagram so I can illustrate this. You know, this is where the spinous process is. So this is the posterior part, this is the anterior part, and this is the lateral part, if you follow my cursor. So what I'm saying here is that the anterior part, the posterior part, and the lateral part are innervated by different nerves. The anterior part is innervated by sympathetic trunk. The lateral part is innervated by gray ramus communicans, while the posterior part is innervated by the dorsal and the ventral rami of L1 and L2. Lateral aspect by ray communicans and the anterior aspect by sympathetic trunk. And it is only the outer 1/3 of the whole disc that is innervated. The inner 2/3 of the disc is completely aneural. You are going to see the relevance of all this anatomy by the time we go into the pathophysiology of lumbar disorders. That is when you will appreciate all this information that we are passing on in the anatomy. All right. So colleagues, we have discussed the osteology. We have discussed the intervertebral disc. Now we want to talk about the anatomy of the joints. What are the joints that exist within the lumbar vertebrae going down to X1 vertebrae? What are the type of joints and what are their functions? All right. The first joint in the lumbosacral segment that we are going to consider is the joint between the lumbar vertebrae themselves. Although when you look at this diagram, you see a lumbar vertebrae, you see an intervertebral disc in blue, you see another lumbar vertebrae. The contact is still being referred to as a joint. Do we understand? The contact, just for the mere fact that there is a contact between two vertebrae, even though it's being separated by intervertebral disc, still refer to the fact that there's a joint there. And the joint between the lumbar vertebrae is called the symphysis joint. I'm sure I'm still going to show you in another diagram. That is called the symphysis joint. And movement do take place. Movement of flexion, extension, lateral flexion, rotation take place as a result of the contact between vertebrae, intervertebral disc, and another vertebrae. That is one of the joints. The second of the joints that is important for us to understand is the joint between the vertebrae above and the vertebrae below. The joint between the vertebrae above and the vertebrae below. If you follow that diagram, you see where it is written facet joint. You know, when I was discussing the features of typical vertebrae, I point your attention to the presence of two superior articular facets and two inferior articular facets. So if you look at that place that is labeled facet joint, it's a point of contact between the inferior articulating facet of the vertebrae above and the superior articulating facet of the vertebrae below. That joint is what is called the facet joint. It is a synovial joint, just like any other synovial joint in the body. And colleagues, that is where osteoarthritis takes place in the spine. If a patient comes to you with a diagnosis of lumbar spondylosis or cervical spondylosis, that is being referred to as osteoarthritis. The exact site of pathology is inside this facet joint, not at the center where the spinal process is. Although the pain could be referred to the center, but the exact point of pathology is lateral to the spinal process, and that is in the facet joints. All right? So I just want to draw our attention to that. Maybe when we come to manual therapy session, we'll discuss how to locate the facet joint and what we can do with it in order to make life better for our patient. So what's the first joint, guys? I've talked about the symphysis joint. This one is also illustrating the facet joint. That's the second joint. There are three joints we are going to talk about in the lumbosacral segment. This is one of them. That's the facet joint between the vertebrae above and the vertebrae below. So we said it is formed between the inferior articulating facet of the vertebrae above and superior articulating facet of the vertebrae below. And I've told you it's a synovial joint. What are the movements allowed by these joints? Flexion movement, extension movement is as a result of the facet joints. It also allows for limited rotation and side flexion. But majority of flexion and extension is produced by the facet joint. And just like I told you earlier on also, osteoarthritis, this is the home of osteoarthritis in the spine, is the facet joint. And you agree with me, it's osteoarthritis in the spine is what we also call spondylosis, all right? It takes place in the facet joint. And the facet joint is also being referred to as sagapophyseal joint. So osteoarthritis takes place in sagapophyseal joint, that is true. Spondylosis takes place in the facet joint, that is also true, because the terms are used interchangeably. The second joint, just like I've explained earlier on, apart from the facet joint, The second joint is the joint between the vertebral body themselves. And that joint is called a symphysis joint. All right? No symphysis joint separated by intervertebral disc, and it has a cartilage, just like any other joint. It's separated from the disc by hyaline cartilage. So that means that joint also can be subjected to osteoarthritis, because the main pathology of osteoarthritis is the wearing away of the cartilage, isn't it? So we can have osteoarthritic changes in the facet joints to a large extent, and we can have it in the symphysis joint to a lesser extent. You know all those changes that come up whenever there is osteoarthritis, like a narrowing of joint space, like sclerosis, like osteophytosis. We can see it in the facet joint, and we can also see it in the vertebral body. Now, what sort of movement is being provided by the symphysis joint? All the movements receive contribution from the symphysis joint. That is flexion, extension, that is rotation, that is lateral flexion here and there. They all received support from the symphysis joint. All right? So that's the second joint in the lumbosacral segment. And the third joint in the lumbosacral segment is the lumbosacral joint itself. And that's the joint between L5 and X1. And you need to take note of this shape, all right? Because some of us that are present during the radiological lecture, you know that we transit to the sacrum by taking note of this shape. Anywhere we see the curve angulation, transiting from rectangular shape to triangular X1, we know the triangular bone is X1, and the rather rectangular bone on top of it is L5. This will also bring to your understanding the point I made earlier on, that L5 is atypical because it is broader superiorly and narrower inferiorly. You can see that very clearly from these joints. So the third joint is lumbosacral joint. Lumbosacral joints also make contribution to flexion and extension to a very little extent, but it makes more contribution to the sacroiliac joint movement of notation and counter notation. We'll talk about that at the right time. We're prepared for all this. Now, we just move on to the slide 32, where we're going to be talking about the ligaments. Now, discussion on the ligament is also important because we get to read about it when we receive radiological reports that a patient is having stenosis due to hypertrophy of ligamentum flavum or hypertrophy of interspinous ligament. So we need to have an appreciation of the understanding of how this ligament actually exists. All right, so we're going to talk about the ligament now, guys. There are 5 essential ligaments. Mark my word, I didn't say there are only 5 ligaments. There are 5 major ligaments in the lumbosacral or in the lumbar segment. Let me not say lumbosacral. There are 5 major ligaments in the lumbosacral area. Now, let me reduce this so I can point anterior to posterior to you again. Now, please watch my cursor. You will agree with me, this is the anterior part of the body. And where the spinous process are located is the posterior part of the body. Yes, you'll agree with me with that. So if that be the case, then the ligament that we're seeing here should be the anterior spinous anterior longitudinal ligament. Okay? And if there's anterior longitudinal ligament, definitely there will be posterior longitudinal ligament. So you can see the posterior longitudinal ligament being projected with a long blue arrow coming from under to the middle there. So there's anterior longitudinal ligament, there's posterior longitudinal ligament. There is another ligament that runs between the lamina. You know, when I was teaching on the body, I asked you to take note of the lamina. It's the lamina that projects to form the spinous process. So if you can identify the spinous process in this diagram, the bone that projects to form that spinous process is the lamina. So there's a particular ligament that connects all the lamina together, and that's the third ligament. And that third ligament is called ligamentum flavum. Ligamentum flavum. And in many cases of pathology of the lumbar spine, there is inflammation there is irritation, and that ligament can get swollen up, hypertrophied, and it can also compress on the nerve root to create clinical condition called spinal stenosis. So we have anterior longitudinal ligament, we have posterior longitudinal ligament, we have ligamentum flavum. There's also another ligament that connects the spinous process together. So what is the best name we're going to call that ligament? We're going to call it interspinous ligament. The ligament that connects the spinous process together, we're going to call it interspinous ligament. And there's yet another ligament at the edge of all the spinous process. And that ligament is called the supraspinous ligament. Now, what the hell is the function of all this ligament? Now, imagine yourself trying to do extension of your lumbar spine and you are going too far. If you are going too far into extension, one ligament is going to stop you. And the ligament that will stop you is the ligament in the anterior part of the body. So the purpose of anterior longitudinal ligament, ALL, is to limit excessive extension of the lumbar spine. Then all other ligaments, from ligamentum flavum, interspinous ligaments, and the rest of them, they are in the posterior part of the body. So when somebody is trying to bend forward in flexion and is doing it in excess, all the posteriorly located ligaments will stop it. So what's the function of this ligament? Anterior longitudinal ligament limits excessive extension, and the rest of the ligament limits excessive flexion of the lumbar spine. All right. So also we still have lumbosacral ligaments, the ligament that run from iliolumbar ligaments that runs from ilium to the lumbar, and we have lumbosacral ligament from lumbar to the sacrum. They also try to provide stability for the sacroiliac joint. You know, sacroiliac joint thrives because of its ligaments providing stability, not because of any muscles. As a matter of fact, the muscles that are connected to sacroiliac joints are not the one producing the movement. They are just contributing to the stability of that part of the body. We'll discuss that at the right time as well. Now, we're going to end this anatomic section by looking at the muscle of the lumbar spine. The muscle of the lumbar spine. What are the relevant muscles in the lumbar spine? Now, the muscles of the lumbar spine will be discussed in this order. We're going to look at the anterior muscles. We're going to look at posterior muscles. Let us start with posterior muscles. Now, if you imagine a patient lying prone on your table and you remove the skin and you remove the subcutaneous fascia, the first set of muscles you are going to see, they are called the superficial group of muscles, and that muscle is called the erector spinae. Now, I want to tell you tonight that there's no single muscle called erector spinae. Erector spinae is a combination of three muscles. That is the spinalis. If you look at that diagram, the spinalis, which is the closest to the spinous process. And after the spinalis, there is longissimus. After the longissimus, there's iliocostalis. Those three muscles together is called erector spinae. And they are the superficial muscle in the posterior aspect of the spine. Now, by the time you cut the erector spinae, you will see two major muscles still left in place. Medially, very close to the spinous process, you will see the multifidus. So the multifidus is the deep muscles, most medial, directly attached to the spinous process. Then laterally in the deep aspect, you are going to find the quadratus lumborum, muscles. So the multifidus and quadratus lumborum are the deep muscles, whereas the superficial muscles is the erector spinae. The superficial muscle is the erector spinae. We're going to look at the function of this muscle in a short while, okay? We're going to look at the function in a short while. Okay, after the anatomy, I think I will plead with the organizer to give off. I don't want us to fall asleep or to feel bored. So maybe we can take 5 minutes, walk around or drink coffee And after 5 minutes, we'll come back and discuss the pathophysiology. But please let us finish this anatomy first. This is unconventional late night lecture. That's why I appreciate your patience and your understanding. Okay? Now, flexion movement. What muscles are responsible for flexion? You know, the way anatomy is that if a muscle is situated in a particular part of the body, the muscle will be carrying out movement in that part of the body. Since flexion is going anteriorly, that means all the muscles that are situated in the anterior abdominal wall will be doing flexion. Since extension is going posteriorly, that means all the muscles that are placed posteriorly will be carrying out extension. And those muscles that are situated laterally will be controlling lateral flexion with support from the anterior or posterior muscles. So following that trend, the flexors of the lumbar spine will then be what? What are the muscles that we can find in the anterior abdominal wall? Rectus abdominis, external abdominal oblique muscles, internal oblique and transversus abdominis. You know, these are the muscles in the front, in the anterior abdominal wall. They'll be the one carrying out this movement you see in that diagram, that flexion. An extension movement, that's the light gray diagram, will be the muscle in the posterior aspect. And like we have said in the previous slide, that will have to be what? Erector spinae, which is the superficial one, multifidus muscles, and quadratus lumborum muscle. It's easier to understand and relate with it that way. Then what about lateral flexion? Some muscles are also attached between the transverse process of the lumbar spine. They are more laterally located and they are responsible for lateral flexion. And these muscles are intratransversalis lateralis and intertransversalis medialis muscles. You can see them as short muscles projecting to the transverse process in this diagram. But you will also remember that the deep muscles, one of the deep extensors, apart from, I told you that multifidus is attached directly to spinous process, whereas the quadratus lumborum is more lateral. You remember that's what I'm participating in lateral flexion. Quadratus lumborum also have a role to play in the lateral flexion of the spine. Okay? So the lateral flexors will be quadratus lumborum, intratransversalis lateralis, intratransversalis medialis. All right. What about rotation? Which muscles will be responsible for rotation of the spine? Now, for rotation to take place, if you can try that where you are seated right now, for you to rotate your trunk to the right, it is your lateral flexors that will contract first. If those lateral flexors are weak, there will be no rotation. For rotation to the right, you will need the right lateral flexors, and then the extensors on the left side will now help you. That is how rotation takes place biomechanically. For rotation to take place, that means we're going to require QL, which is the quadratus lumborum. We're going to need intratransversalis lateralis, intertransversalis medialis, and we're going to need extensors on the opposite side, which will be multifidus and the erector spinae. So these are the muscles and the function in the lumbar spine. Now, our discussion on the anatomy of the lumbar spine will not be complete without making mention of the lumbar stability system or spinal stability system. All right? You know, our spine, one of the functions it was designed to do is to keep us stable. So that whether we sit down, whether we stand up, whether we are running, whether we are walking, whether we are jogging, there should be no pain. There should be no compression on the pain-sensitive structure. But when you see a patient, when a patient complains that if you sit down for a certain number of hours, he's having pain. If you stand up for a certain period of time, he's having pain. That points to the fact that the stability of that spine has been compromised. Because whether in sitting or in standing, the spine is so designed that it will be stable so that there will be no wobbling movement that will lead to compression on pain-sensitive structure. So what are these stability systems? What are these structures that are responsible for the stability of the spine? Three major systems, according to Punjabi Theory of Lumbar Stability, 1994. The man Punjabi enabled us to understand that the stability of the lumbar spine is a system. And because it's a system, that means it has different organs. And those different organs can be reorganized into subsystems. So we have three subsystems under the lumbar stability system. Those subsystems are passive subsystem, active subsystem, and the neural subsystem. All right? This diagram is saying that the passive subsystem is just the spinal column, the non-contractile elements. You know, the major contractile elements in our body is muscle and tendon. They are the ones that contract. Even though ligaments also contract, but only when it is stretched to its limits. That's when ligament generate tension. So ligament is still a non-contractile element. So the bone and the ligaments, they are non-contractile elements in our body. And they are the ones that make up the passive subsystem. The muscle and the tendon, that are the contractile elements, make up the active subsystem. And of course, you know, for stability to take place, the brain must be in control. The brain must be receiving afferent inputs, and it must be sending efferent inputs to keep us balanced and stable. So the central nervous system is the one that constitutes the neural subsystem. So lumbar stability system is anchored on three subsystems: passive subsystem, active subsystem, and neural subsystem. We're going to see them in a bit more detail in the next diagram. So let us talk about the passive subsystem. As you can see in that diagram, you see a diagram of bone, bone, bone. What bone do we have there? We have the vertebral column, we have the intervertebral disc, and we have the sacrum. With all the ligaments, they made up the what? Passive subsystem. Right? I know we have diaphragm, pelvic floor, and other transversus abdominis. They are not part of the passive subsystem. This diagram is just showing the link. The passive subsystem is just the bone, the joints, you know those three joints we have mentioned, the symphysis joints, the facet joints, the lumbosacral joints, the bones, that is the spinal column and lumbosacral segment, and the ligaments. Now, without this structure, we cannot have a stable spine. All right? Nobody can walk from one point to the other with just muscle alone, without those muscles being attached to a bone. So you see that passive subsystem is very important component of the lumbar stability system. They enable us to carry out movement. So they are responsible for both static stability and dynamic stability. I know it is muscle that contract to produce movement, but without muscle being attached to this bone, even dynamic stability will not take place. All right? And they give us stability by preventing excessive movement in one direction. Like I talked about the ligament the other time. All the ligaments that are located posteriorly will provide a check and balance to excessive flexion. And all the ligaments that the anterior longitudinal ligaments will stop excessive extension. That is stability. That is stability. They restrain excess motion in both flexion and extension. And they help the muscle to anchor so that dynamic stability can take place. So when you think of the bone, the joints, and the ligaments, you are thinking about the passive subsystem. Then the active subsystem. The active subsystem, just like I told you, is the contractile element. And the contractile element in our body is what? The muscles, the tendon. Maybe we can also include the fascia. All right? Just like I said earlier on, that nobody can walk about with muscle alone when they are not attached to bone. The same thing is the case. Nobody can walk about with bones alone without the muscles. If you look at the diagram on my left-hand side, you see the diagram of somebody bending downward. Why? Because ordinarily, if you arrange the bone in human body to stand, gravity will push it to the ground. So what element is preventing gravity from pushing our body to the ground? They are the muscles. Is the active subsystem. Will you then wonder why after old age, after about 65 or 75 years, people no longer are able, some people are no longer able to walk straight because the active subsystem is now weak and gravity is now pushing the passive subsystem more towards the ground. But by the time they were like 30, 40, or 50, when their active subsystem is still very active, the active subsystem will contract isometrically and withstand the forces of gravity. So the active subsystem is made up of muscle, tendon, and fascia, and is responsible for dynamic stability. You know, when we are turning, when we are running, we are still stable. When we are jumping, we are still stable. That is dynamic stability, and that is responsible for by the active subsystem, whereas passive stability is mainly the function of the passive subsystem. But passive subsystem also contributes to dynamic stability. All right. You know, like I said, the passive subsystem provide place for the muscle to be attached. And when you also look at the ligament, there are receptors inside the ligament and tendon. You remember Golgi tendon organ? They are also providing apparent input into the central nervous system, which enables central nervous system to keep our stability. So the passive subsystem is very important. It's as important as any other subsystem in the body. Okay. They want to look at the last system in the lumbar system component, which is called the neural subsystem. Of course, when we say neural subsystem, we're referring to the central nervous system. You know, it is possible for somebody that has stroke. Let me just start discussion from here. You've seen a stroke patient before. You've seen the way stroke patients are walking, you know, before. Let's say like a 35 or a 40-year-old person that have stroke. Do they walk straight with their spine? So because they are not walking straight with their spine, we can say that's a kind of instability. But will you say something is wrong with their bone? No, nothing is wrong with their bone. So that means the passive subsystem is okay. Would you say something is wrong with their muscle? No, nothing is wrong with their muscle. So that means the active subsystem is okay. Where is the problem coming from? From the coordinating center in the central nervous system. Even though an individual have a perfect passive subsystem, a perfect active subsystem, and the controlling unit of the central nervous system is not functioning, the stability of the spine will be lost. So the function of the neural subsystem is to receive information from the passive and the active subsystem and provide appropriate feedback to control both the active and the passive subsystem so that the spine will still be able to maintain its stability. Don't forget, passive subsystem is responsible for passive stability and it helps with active stability or dynamic stability. The active subsystem is responsible for what? Dynamic stability. Central nervous system is responsible for the control. If the function of one of these three components is deficient, something will go wrong with stability of the spine. Now, let's come down to physiotherapy for low back pain. Now, if you have a patient of about 65 years old or 50 years old with a very bad spondylosis, okay, we say spondylosis, osteoarthritis. Okay, osteoarthritis also takes place in the passive subsystem. You agree with me? The osteoarthritis is cartilage problem, and cartilage is between bone, isn't it? So the passive subsystem is the major culprit, is the major offender in spondylosis. But when after you've done your assessment, you now begin to train the patient on core stability exercises, back strengthening exercises. What are you working on? You are working on the active subsystem to compensate for the deficiency in the passive subsystem. So these subsystems are interdependent on one another. And I've also told you that even though the passive and active subsystem are okay, and the neural subsystem is not functioning well, there will be problem. So that in nutshell, we'll conclude our section on anatomy of the lumbar spine. I will plead with our organizer to please give 5 minutes break. Let us have 5 minutes break, please, so that people that want to ease themselves can ease themselves. If you want to sip a little coffee, please do so. I will come back around 9 o'clock exactly. I'll come back 9 o'clock exactly to make the next presentation. Thank you very much. Thank you for this session. Let's have 5 minute break, please, for the next session. Okay, guys, good evening. You are welcome to the second session. I hope you've been able to go to toilet or have a sip of water or coffee. I still plan another session out. I think they gave us 8 to 11. I know it's odd hour to give lecture, but we'll do our best so that it will not be a burden. Try and make it as lively as possible, although the section of anatomy and pathophysiology is not as lively as the hands-on session if we're able to do it practically. So you are welcome to the second session anyways. I have already projected that on our slide. So I projected that on our slide for us to see. I believe you can still hear me. If you have a problem with my audio, please kindly notify me. All right. So the lumbar spine pathologies. What are the different conditions that could happen in the spine that will make patients come and see us? That's why we have to do the anatomy first, so that when we're talking about these features here, we will not be lost. All right, we'll be on the same page. So what are the learning objectives for this section? By the end of this section, I'll expect my listeners to understand the causes and classification of low back pain based on different criteria, including the criteria by Clinical Standard Advisory Group, CSAG 1994. By the time we finish, all of us should have very good understanding of clinical features of low back pain and back disorders, some tests, treatment indication, and then, like I told you, I've already planned to have a hand-on practice, most likely when the alubalu about this protest go down, so that we can enter into the lab during the day and then present and then do the hands-on session. All right, please bear with us. All right, so let's go on. The back pain, I'm sure many of us have been defining back pain and low back pain previously in our previous endeavors. So we can see that back pain is a pain, can be defined as any pain of any nature that is felt ranging from the rib cage to the pelvis. I want to take note of my word, rib cage to the pelvis. I didn't say from the lower end of the rib cage to the pelvis. If I said that, that would be low back pain. But back pain generally encompasses the rib cage down to the pelvis. But if you now compartmentalize it to say that the pain from the lowest part of the rib cage to the pelvis, then you'll be talking about low back pain. All right? Before we go into the pathophysiology, in fact, this classification will usher us into the pathophysiology. It's going to usher us into pathophysiology. Let's look at classification of low back pain. How is back disorders or back pain classified? All right, there are different criteria in the 80s and 90s. Some people will come with this criteria, some will come with that criteria. But the most popular among them are the ones that we are going to discuss. This is classification based on the duration of the pain. I'm sure we are all familiar with this as well. Classification based on duration of the pain. You know, based on duration of the pain, if the duration of the pain is less than 6 weeks and is occurring between the lowest part of the rib cage and the pelvis, we're going to say it's an acute low back pain, less than 6 week duration. And this is what many of us have suffered in the past. I'm sure all of us, almost all of us, no exception, would have felt pain in our lower back for less than 6 weeks before. So acute low back pain itself is not a serious problem because it often gets resolved even without intervention, without medication, without physiotherapy. Only 3% of cases with acute low back pain will enter into the chronic phase. So, and it's only those 3% that are giving us all the burden that we are having about managing low back pain today. So generally, acute low back pain is any pain lasting for less than 6 weeks And bear it in your mind that most of these cases recover even without any intervention. Well, some of the individuals with acute low back pain will have their pain progressing beyond 6 weeks. So it will be any pain lasting for more than 6 weeks, but less than 3 months is said to be subacute low back pain. That is subacute low back pain. Now, this subacute low back pain is a period of worries. That's when patients will get worried that their pain has been there for 6 weeks. They have taken ibuprofen. They have taken diclofenac. The pain is not relieving, and they begin to get anxious. Some of them will get depressed. They begin to avoid movement because the thoughts, if they carry out a particular movement, their pain will come back. And some of them begin to exaggerate their pain experience. That's pain catastrophizing. So all these psychological or psychosocial traits happened in the subacute stage. And it goes on to the chronic stage. That is where when we are managing a patient for low back pain and they are within the subacute to chronic stage, we also have to include psychosocial measures in our assessment and in our treatment. All right? But basically, any pain that is more than 6 weeks and less than 3 months will be said to be a subacute pain. Some of them will still recover, but a tiny percentage will not recover and enter into 3 months. So any pain that has lasted for more than 3 months, it might be 1 year, it might be 4 months, it might be 3 years, it might be 10 years. As far as it is more than 3 months, it is chronic. And this chronic category also have these psychosocial traits, including depression, anxiety, fear avoidance, belief, and pain catastrophizing. They are all there. Then the fourth category is the one we call acute on chronic pain. When do we have acute on chronic pain? That's a patient whose pain is already chronic and he receives some treatment, maybe medication or physiotherapy, and the pain subsides. And after some time, he did some movements or something, and the pain come back. And it's looking like the acute case again. So we say that is acute on chronic or recurrent pain. So based on duration of the pain, colleagues, we can classify back disorders as acute, subacute, chronic, or acute on chronic. So that's a criteria for classification. Oh, have I jumped slide? All right. I think there's a mix up in my slide. That's what I'm okay. No, not a mix up. You know, I did some addition on my slide. If I teach this class this year, the way I'm going to teach it next year will be different because I do research even before I give lecture. So this slide is an addition to the one that was given last year. Now, I'm still trying to categorize acute and chronic back pain. I'm bringing out more points that will be relevant for physiotherapy practice, okay? When we are applying treatment to this category of patients, acute or acute, which of the treatments within our domain are well supported by evidence and which one are not well supported by evidence, right? When we're dealing with acute and subacute pain, you know, we've divided them based on duration. If you want to go the way of non-pharmacologic treatments, according to treatment guideline for acute and non-acute, non-pharmacologic treatment has moderate quality evidence, and that's fantastic. And the non-pharmacologic treatment will include the non-pharmacology treatment that was mentioned in the treatment guideline include our superficial eating system for acute and subacute. Another low quality evidence. So the therapeutic that we give is of moderate quality evidence. I'm trying to summarize a recent treatment guidelines on low back pain. This is very recent compared to what we have in the past. This guideline is less than 5 years. So it's stipulating that superficial heating system or physiotherapy heating system is allowed. It has a moderate quality of evidence for acute and subacute low back pain, whereas spinal manipulation, acupuncture, and massage has low quality evidence. They have low quality evidence. So the question I want to, or the point I want to make to you is this. If superficial heating has moderate evidence, all right, acupuncture and massage and spinal manipulation has low quality evidence. What is going to happen by the time we combine spinal manipulation with superficial heat? All right. You know, by the time we combine manipulation with superficial heat, we'll be getting a better quality treatment to patients in subacute or acute phase. All right. Now, for pharmacologic treatments, when a patient is in acute or subacute, we'll give them the non-steroidal anti-inflammatory drugs and muscle relaxants. That is what the treatment guideline recommend. All right. Now we're going to the acute phase. The treatment guideline recommendation for this one. Based on recent treatment guideline, there's a strong recommendation when a patient has entered into chronic stage. There's a strong recommendation that we should do a multidisciplinary rehabilitation. All right. What do I mean by multidisciplinary rehabilitation? Physiotherapists will have their own role to play. Maybe occupational therapist, psychologist, and other relevant professionals. Now, look at acupuncture here. Because acupuncture is within the domain of physiotherapy. It has a moderate quality for chronic low back pain. And mindfulness based on stress reduction has a moderate quality. The low quality evidence in recent guidelines include motor control exercises, which are spinal stability exercises, relaxation, and other therapy that are listed there. But the point I'm trying to make to you, colleague, is that if any of our treatment intervention come under moderate or low quality evidence, it's a good thing. Because by the time you combine two low quality, you will get something in the moderate quality. And by the time you combine one moderate quality with one low quality, you'll be doing very good work to your patients. So you can see here that our spinal manipulation, acupuncture, and therapeutic heat, they will be very useful to deal with different stages of low back pain, according to recent treatment guidelines. All right. This is still recommendation for chronic low back pain, that if a patient is having chronic low back pain and the chronic low back pain is not responding to conservative treatment, what is the recommendation? Start pharmacologic treatment with anti-inflammatory like diclofenac or ibuprofen. If that is not going to help, then we'll proceed to tramadol. If that's not going to help, then we proceed to opiates. All right. But the physician must weigh the benefits and the risk of giving opiates, and it should be prescribed based on the peculiarity of the patient. I thought that would be a useful information so that we don't just talk about acute and chronic and we just leave things like that. At least now we know the treatment within our domain that we go. Please, one microphone is on. If your microphone is on, please. Mute your microphone. Please mute your microphone. Somebody's microphone is unmuted. So please try and mute your microphone so that it won't affect others. All right. Okay. So another classification, this classification is based on response to changes in posture and movement. I'm sure many of us would have heard this one also. When a low back pain patient or a back pain patient comes to your clinic and you put them in different positions, the pain is just the same thing. No position is relieving the pain. No position is making the pain worse. That's what we're talking about. Classification based on response to changes in posture and movement. What do we have in this category? We have three categories under this response to movement and posture. The first group is mechanical back pain. Which one do we call mechanical back pain? These are patients whose back pain respond to movement or posture. I'm sure you would have seen many of our patients that will say, when I'm walking or when I'm standing, my pain is much, but immediately I sit down, my pain eased off. That shows that the movement, the pain is responding to posture and movement. But there are some patients that their pain would not respond, whether they are seated, whether they are standing, whether they are walking, the pain is just the same thing. Even when you examine them, when you ask them to do flexion, extension, the pain is just the same thing. We'll call this category of pain non-mechanical back pain. And most non-mechanical back pain are usually due to internal organs involvement. It can be viscerogenic, it can be due to cancer, carcinogenic, and it can be due to psychological disorder, or it can be due to malingering. That is non-mechanical low back pain. Of course, you know, when we say something is mechanical, it must have to do with movement apparatus. And what are the movement apparatus in our body? The muscle, the tendon, the ligament, the bone, the joints. So most mechanical low back pain are due to this structure, but non-mechanical low back pain are usually due to viscerogenic, carcinogenic, psychogenic, or malingering. And it is also possible to have a patient that will have a combination of mechanical and non-mechanical causative factors. So that's the mixed factors. So based on this classification system, we can say that back disorder can be mechanical, non-mechanical, mixed in nature. We still have a third and a very interesting category. This is the one that is going to usher us into the pathophysiology. And this is classification given by Clinical Standard Advisory Group, CSAG UK, 1994. You know, because of this confusion with different people coming up with their own classification system, in the 80s, a group of professionals that are involved in the management of pain, including physiotherapy, surgeon, and anesthetists, they were grouped together in the UK, and their responsibility is to come up with a classification system that will be acceptable for practice and research. So they put their head together, and what they come about, the classification system they produce is what is being referred to as the classification by CSAG UK 1994. I'm going to look at that classification system in a nutshell. This advisory group came up to say that, look, guys, we are going to classify all back disorder into three. The first category will be called non-specific low back pain. The second category will be called nerve root pain. And the third category will be called pain due to serious spinal pathology, SSP. All right? Before we go into the details of each of these categories, I want to say that 95% of patients that come to us in physiotherapy clinic are due to non-specific low back pain. They constitute majority of the patients with back pain. And that's why you see they have a large segment in that pyramid. 95% of cases of back pain are non-specific. Less than 4% of patients that we treat are those that have pain of nerve root origin. And less than 1% of them are people that have pain of serious spinal pathology. So we are going to examine each category one after the other. But before we examine the categories, you know, it makes sense to just imagine, isn't it, that if a classification is saying that one group is non-specific, so that means the rest of the group, we can term them as specific, isn't it? It's just a simple logic. If you are telling us that this one is specific, then the opposite of specific will be non-specific. What I'm trying to say is that if 95% is non-specific, then the 4% and 1% here can be said to be what? Specific, low back pain. Whereas this group will be said to be non-specific, low back pain. That's exactly what this slide is trying to illustrate. That's classification by DCSAG can also be looked at in this way by saying there's specific back pain, there's non-specific back pain. So we're going to examine each of these categories one after the other. Let us start with that 95%. Majority of those patients that we see that are non-specific low back pain. How do we recognize them? What are the salient features that this patient will be presented with? Follow me as I go into the slide. Now, when a patient is having non-specific low back pain, the implication is that, I've told you, the implication is that their pain could be caused by a single mechanical factor or a combination of mechanical factor. I've told you the mechanical factor. When you say mechanics, that is movement. And what are the structure responsible for movement? Muscle, tendon, ligaments, bone, joints. If there is disorder in any of this structure, it gives birth to mechanical low back pain. So mechanical low back pain is an example of non-specific low back pain. All right? Because in non-specific low back pain, it could be caused by a single or a combination of anatomical structure. It can be due to joint problem, degenerative changes. Muscle is also affected. Ligament is also affected. Bone is also shifting. It can be due to a single or a combination of factors. That is non-specific low back pain. And point number 2 is trying to say that, like I said, all mechanical low back pain are non-specific low back pain. And the third point that will be useful to identify this patient is that when a patient with non-specific low back pain come to your clinic and you ask them where is your pain or how has the pain been, they will not be very straight to the point. They can tell you that, oh, the pain was in my upper back last month, but this month I observe it's going to the right side of my waist. And last week it has just moved to the center of my back. A vague description, difficult to localize pain. They can even tell you that it's very difficult for them to localize the pain. When they give a vague description of their pain like that, it is more likely that their pain is what? Non-specific. All right? And also, essentially, all non-specific low back pain are very highly recurring in nature. So the patient can give you the story of like, oh, initially when this pain started about 3 years ago, it was really much. After I received some treatment, the pain went down. But I don't know what I did. In the last 2 weeks or 4 weeks, the pain has come up again. So the recurring nature is a peculiar feature of non-specific low back pain. Are you with me, sir? Then the last point is that all cases of osteoarthritis can produce non-specific low back pain with explanation. All right? Most cases of osteoarthritis, osteoarthritis in the spine we call spondylosis. Most cases of osteoarthritis can produce non-specific low back pain. How are we going to know that this spondylosis is producing non-specific? There will be early morning joint stiffness of less than 30 minutes in duration. That is, if the patient wake up in the morning, their back will be stiff and painful, and they'll be struggling to move the back. For a period that is less than 30 minutes, it can be 1 minute they have to struggle for, it can be 5 minutes, but generally, the period should be less than 30 minutes. Early morning stiffness. And after they sit down in one position or stand in one position without movement for about 45 minutes, this stiffness will also come. So when you see the sign of stiffness like this, it's most likely the pathology is osteoarthritis, and we can put it under non-specific low back pain category. What other features will enable us to identify spondylosis or osteoarthritis? By the time you carry out your physical examination on them, you are going to ask them to do flexion, extension, right side flexion, left side flexion, right rotation, left rotation. You are going to observe that the same movement they produce in left side flexion will be the same movement they produce in right side flexion. Equal movement in side flexion. Equal movement in rotation. Right rotation and left rotation will be equal. So this is a pattern. of movement you will see in patient that has spondylosis that you might not see in a patient that have intervertebral disc prolapse or patient that has spinal stenosis. You might not get equal side flexion and equal rotation. So whenever a patient is presented with equal side flexion and equal rotation, you will call that capsular pattern. And capsular pattern is 100% due to osteoarthritis. So whenever you examine your patient and see they have equal side flexion and equal rotation, be free to diagnose spondylosis. And that is an example of non-specific low back pain, because this is the capsular pattern. The equal limitation in side flexion and rotation is the capsular pattern for the spine, whether cervical spine, thoracic spine, or lumbar spine. All right? What's the other features that will enable us to know that they are having spondylosis or osteoarthritis? Now, any patient with back pain that involve nerve root, how would we know that nerve root is involved? The pain will be referred from the back to the leg, isn't it? That is outside non-specific low back pain. Do you understand, guys? As long as you are noticing nerve root involvement is falling, that is falling into another category. In non-specific low back pain, there must be no nerve root involvement. Do you understand? That's why you have on the right-hand side of this slide, the neurological symptoms. What are the neurological symptoms? How are we going to know that nerve root has been compressed? The dermatomes could be affected. The myotomes could be affected. The straight leg raising test, they will come up. Immediately you have all those ones, you know it is not non-specific low back pain. But if you test your patient and you find out that the dermatome, the myotome, the reflexes, and the straight leg raising test are negative, then you will know that it is osteoarthritis and it is also a non-specific low back pain. But if you have a patient that shows early morning stiffness of less than 30 minutes, and then is having pain going to the leg, and SLR test is positive, even though it is osteoarthritis, you will not categorize that as non-specific. In non-specific, there is no nerve root involvement. All right, so this is the first category. 95% of patients that we treat, they fall into this category. All right, now I have talked to you about capsular pattern. The capsular pattern in the lumbar spine is characterized by what? Equal movement on the side flexion. Right side flexion must be equal to the left side flexion. Right rotation must be equal to the left rotation. Once we notice that pattern, my brother, it is spondylosis. And if there's no nerve root involvement, it is non-specific low back pain. All right? The most common causes of this capsular pattern is arthritis, which is also what we call spondylosis. Okay? Can we now leave the non-specific low back pain so we can identify these non-specific people now? Let's move on into the specific. What are we going to get in the specific? We are going to get nerve pain, that's less than 4%, and we are going to get pain of serious spinal pathology, that is less than 1%. Okay? So let's take it one after the other. Let us discuss the nerve root pain. You still remember this? I'm still on this. We have discussed the non-specific. Now we are going to what? Nerve root pain. All right? Now, what causes nerve root pain? That is where we're going to start from. You know, less than 4% of these patients that we treat with low back pain will have nerve root pain. What usually causes nerve root pain is because the nerve root is compressed. You remember when I was discussing the anatomy of the vertebrae, I said there is a vertebral foramen where the nerve root exits. You can see the nerve root in yellow here. So any pathological condition that leads to compression of nerve root has given rise to this second category called the nerve root pain. And what are these conditions? Disc herniation. All right? If the disc is protruding or it's coming out from its original position, we call it disc herniation. But if the disc is herniating and is also compressing on nerve roots, that's what I wrote here as disc herniation with nerve root compromise. Then that is nerve root pain. All right. If there's spondylosis, we know what is spondylosis. That is osteoarthritis. And we know some of the changes that take place during spondylosis. There'll be joint space narrowing, isn't it? There'll be osteophyte. If osteophyte is coming out as a result of osteoarthritis, and that osteophyte is not touching the nerve root, that will be non-specific. But if the osteophyte is compressing on the nerve root, then that will be nerve root pain. That's a different category. That's why you see point B here saying osteophytosis with nerve root compromise. All right. Another potential sources of nerve root pain is stenosis. You remember also when we're dealing with the anatomy, I told you about the central canal where spinal cord passes through and the vertebral canal where the nerve root passes through. If this canal, either the central or the lateral, gets narrowed, there will be compression on the nerve root. And that will give rise to stenosis. Because nerve is involved, spinal stenosis with nerve root compromise is another source of nerve root pain. That's why you have A, B, and C in that diagram. Do you understand? Now, more than 60% of nerve root pain occur between L4, L5, L5, X1. Majority of our patients, that's where they have their pathology. Even majority of the spondylosis, the osteoarthritis, is between L4, L5, and X1. Nerve root pain, L4, L5, X1. Stenosis, L4, L5, X1. All right? But the nerve root pain mostly occur in individuals between the age of 30 to 55 years. If you have a children that is less than 18 years and is complaining of nerve root pain, or an elderly person that is more than 70 years complaining about nerve root pain, my brother, ask them to go and do MRI because that is not expected. So it might be a serious spinal condition that is causing their nerve root pain. So that is why less than 18 years and over 70 years are red flags. We are coming to that very shortly. So you understand what could give rise to radiculopathy now, or radiating pain. Disc herniation with nerve root compromise, osteophyte with nerve root compromise, spinal stenosis with nerve root compromise. Now, we are going to spend our time to look more at the disc herniation with nerve root compromise. So we are entering into the pathophysiology gradually. We want to talk about disc herniation and how that could lead to nerve root compromise and how our patients will be presented. In this session, you are going to have understanding of how two patients that come with the same MRI findings will have different clinical features, if you follow me very attentively. All right, let's start from this very simple point of view. The three types of disc herniation, all right, the three major types of disc herniation that exist is prolapse. Prolapse is also called protrusion. Then there's extrusion. Then there's sequestration. What is prolapse or protrusion? In prolapse, you see the nucleus is pushing, isn't it? You can see the bluish nucleus pulposus. It has lost all its water, maybe as a result of aging. It has lost all its water and it started behaving like annulus fibrosus. You know, when we discussed the anatomy again, I told you that 60 to 70% of nucleus is water. But as a result of aging, the nucleus lost its water. So it will now be like annulus that have less water. And it will start pushing on the annulus fibrosus. Can you see the protrusion there? So if that protrusion should touch a nerve root, then there will be nerve root pain. All right? In extrusion, that's the middle diagram, the nucleus is pushing with so much force that the annulus fibrosus has broken. You also remember during the anatomy, I told you during the anatomy that the collagen fiber in the annulus fibrosus are arranged at an angle in multi-direction to be able to resist the nucleus pulposus. But if the nucleus is pushing with so much force, the annulus will open. And both of them, if they compress on the nerve root, there will be nerve root pain. You know, the pressure that will be coming from extrusion on the nerve root will be greater than the pressure that will be coming from prolapse or protrusion. Now, the third one is the sequestration. In some extreme cases, the pressure is so much that the herniated disc even get broken into fragments. You can see some fragments in that sequestration. And those fragments will go to different levels of the spinal column. So the compression on the nerve root will not be only at one segment. If this is taking place at L5 and there is sequestration, segment has gone to L4, another one has gone to X1. Even though the pathology is at L5, patients will be reporting pain and symptoms at these three segments. So there can be prolapse, extrusion, sequestration. Prolapse is when nucleus is pushing and the annulus is containing it. Extrusion is when both nucleus and annulus fibrosus are compressing on nerve root. Sequestration is when there is a massive herniation and the disc even get broken into fragments, and the fragment move to adjacent segments to cause compression on the nerve root and other pain-sensitive structure in the spinal column. All right? Let us talk about prolapse first before we move to extrusion. Remember, guys, that I said that prolapse is also known as protrusion, and prolapse happens when nucleus is pushing, but the annulus is still containing it. Do you understand? Now, the direction of the herniation with prolapse can be either one of these two. The direction of herniation can be central. That is what we call posterocentral. That is, the nucleus and the annulus fibrosus are pushing centrally towards where the spinal cord exists. Another variety of prolapse could be posterolateral. That means the nucleus and the annulus that's the upper diagram. They are pushing posterolaterally, and where are they going? They are going to compress on the spinal nerve root. And you know, if they compress on the spinal nerve root, pain will go to the lower limb. In the posterocentral, the pain might not go to the lower limb because the nerve roots are not at the central part. They are the lateral part. So the two varieties of prolapse or protrusion are the posterocentral prolapse and posterolateral prolapse. And you might be reading this terminology in some of the MRI reports that your patient will bring. So you will know the implication once you read posterocentral. There might be no compression on the nerve roots. Posterolateral, definitely there will be compression. The only situation where posterocentral get dangerous is when there is massive posterocentral protrusion. If it is very massive, even though it's going centrally, it will end up compressing on both nerve roots from the right and the left side. So the patient will come to your clinic and tell you that they are feeling pain in their right leg and their left leg because the herniation is posterocentral, but it is big and is resulting into compression of nerve roots both on the right and on the left. Do you understand? Now we go to the next slide. This is posterocentral. We are still on disc prolapse, so that's a situation where nucleus is pushing and annulus is containing it. If it is posterocentral disc prolapse that you are having, what are the features that the patient will be presented with? If it is posterocentral, they will report pain immediately. There is prolapse. Immediately that prolapse happened, immediately they heard the sound in their back, there will be pain. That is acute back pain. And the pain will be radicular. It will be radiating. For example, if the prolapse happened in the upper lumbar segment, by the time you test myotome and dermatome, you will know. It can be radicular and extra segmental. And their pain can be aggravated by forced expiratory maneuver like coughing. If there's posterocentral prolapse, there'll be acute back pain. If you ask that pain to cough, it will cough and the back pain will increase. there will be no leg pain. And the leg pain will not increase with coughing. That's how you know it is posterocentral. Immediately the patient cough and the pain is in the back and the leg, it's more likely to be what? Posterolateral. How else do we know the posterocentral disc prolapse? By the time you carry out your range of movement assessment, you know the one I call capsular pattern some few minutes ago. Capsular pattern is when there is equal flexion, equal side flexion, and equal rotation. And I told you that one is mainly due to what? Osteoarthritis. Because this one we are discussing here is not osteoarthritis, it is disc herniation. The movement pattern you will get with your patient will be non-capsular. It's not going to be the capsular pattern. It's going to be non-capsular pattern. That is, you will not get that equal side flexion and equal rotation. Do you understand? However, point number D, there will be no neurological deficit. There will be no sign of dermatome or myotome, or straight leg racing will be negative. Why? Because the prolapse is posterocentral. It's only when it goes posterolateral that it can compress nerve roots. And it's when the nerve roots are compressed that you have neurological symptoms. But remember, I told you, except if the posterocentral is big and massive, that is now resulting to compression of both nerve roots, even though it's going centrally, it's now compressing on both nerve roots, then there could be neurological symptoms. But normally, a patient with disc prolapse in your clinic, it worked very well. It's not showing lateral shift, bending to one side. Why is it not bending to one side? Because the prolapse is posterocentral. If the prolapse is posterolateral, it will bend to one side. It will bend away from the side of the pain. So the patient comes with MRI showing disc prolapse, but it's walking without bending to one side. You ask him to do flexion. His flexion is complete. Extension is a bit problem, but it is non-capsular. And there is no SLR is negative, dermatome is intact, myotome is intact, then you will be thinking of posterocentral disc prolapse. Remember, we are still on prolapse, so we have not entered extrusion. And you remember what we said in prolapse, nucleus is moving, but the annulus is holding it. So we have discussed posterocentral. Now let us discuss posterolateral disc prolapse. How does it happen with posterolateral disc prolapse? The prolapse or the herniation will go posterolaterally. And you know the nerve roots are on the lateral side, so there will be compression on the nerve roots. So what are the symptoms? Acute back pain. Immediately it happens, there will be pain. The pain is also radicular and segmental. Now, see point number C. The pain here will be associated with what? Lateral shifting. That's when you see the patient bending and walking with their spine bent to one side. They bend away from the side of the pain. Unlike what you have in posterocentral. Well, when you assess their range of movement again, it will be non-capsular. Remember, capsular is only produced by what? By osteoarthritis or spondylosis. And this is not a case of osteoarthritis. So the movement pattern here will also be what? Non-capsular. Now, you know, in this posterolateral, there's compression on the nerve roots. So we are going to expect some neurological sign to be present, isn't it? So what neurological sign are we going to expect? The straight leg racing test will be positive. You know those other tests that we do to confirm straight leg racing tests, like Lasegi test, Neri test, they could also be positive. But for dermatome and myotome to be present, there must be a very huge compression on nerve roots. And don't forget that this is prolapse. The annulus has not opened. So the compression on the nerve roots is not that very huge. So dermatome and myotome are usually absent in this group of patients. You will test their dermatome and their myotome, it will be normal. But you will see that straight leg racing test is positive. And you will see that they shift their body away while they are sitting, while they are walking. Do you understand? And they have non-capsular pattern of movement. So you will know that this is posterolateral disc prolapse. This posterocentral and posterolateral also have implication for practice. They have implication for manual therapy. The kind of manual therapy you will do when your patient is having posterocentral might be different from what you will do when it is posterolateral. So we are not just saying this for fun. We need to know this point as a serious musculoskeletal physiotherapist. All right, let us leave prolapse. We are going to leave prolapse for a while. You know, prolapse is, again, protrusion, and that is nucleus compressing on annulus, and annulus has not broken. Let us go to that situation whereby the annulus will be broken. And that is the one we call disc extrusion. That is disc extrusion. So you can see in the diagram above, the nucleus has lost its water, is behaving like annulus, is pushing the annulus, and the annulus has opened. So this one is going to go, they usually go posterolateral. Anytime you have this extrusion, it is posterolateral. It doesn't have posterocentral version. Do you understand? So that means it's going to compress on what? Nerve root. And that means all those neurological signs will be present, including myotome and dermatome that we said is absent in prolapse. It will be present here. Why? Because the compression is huge. It involves both annulus and nucleus pulposus. So anyway, let us read from the slide. A disc extrusion is a herniation characterized with what? Tear in the annulus. As a result of the tear, it can even lead to inflammation around the area of the pathology. What are the variety of disc extrusion? If you take your mind back to prolapse, I told you we have two varieties of prolapse. What are the two varieties again? Posterocentral and posterolateral. But when you come to extrusion, they are mainly posterolateral, but they still have varieties. What are the varieties? Monoradicular, polyradicular, and primary posterolateral. That is the ABC. The three varieties of this extrusion are monoradicular, polyradicular, and primary posterolateral. We are going to examine them one after the other. Now, this is illustrating a case of monoradicular. For some of you that have been with us when we discussed the imaging, you will have a better understanding of this diagram. But for those of you that are not even with us, if you look at this diagram, you see the white segment. Okay, let me take it off screen. You see this white segment here represent the vertebrae, and the dark area here represent the vertebral disc. And you can see at this segment that the vertebral disc is going posteriorly to where the spinal cord is and to where the nerve root is, compressing on the nerve root. But this is only happening at one segment. So we are going to call it monoradicular extrusion because it's only at one segment. Do you understand now? Now, let us now consider what will be the clinical features when we have monoradicular. Again, there is going to be pain, acute pain. Everything that we have said about posterolateral prolapse will also be present here. There will be pain. But here, the pain will also be going to the leg. If you ask this patient to cough, they will feel the pain in their back. They will also feel the pain in their leg. This patient will also do lateral shift, you know, because the herniation is posterolateral. It is not posterocentral, so there will be a lateral shift. If you test their range of motion again, it's not going to give you that capsular pattern. Remember, I told you capsular pattern is only for what? Osteoarthritis. This group of patients find it difficult to do flexion more than any other thing. Flexion will be so painful that they will not be able to do it. Even extension will be painful, but their flexion will be more painful than extension. Now, when we come to neurological deficits, by the explanation I've offered so far, you know they are going to have neurological deficits. But how will their own neurological deficit be different from that of prolapse? Here, they are going to have dermatomes and myotomes. In prolapse, there's no dermatome, there's no myotome. It's only straight leg bracing. So if you look at the F part here, the neurological deficit, SLR, Lasegi test, they are positive. Other neurological tests like dermatomes and myotome will also be positive. Whenever you have that, you know you are dealing with a massive disc herniation in form of extrusion. So you see, it's possible to have 3 patients that will carry the same diagnosis, but they will present with different clinical features. All right. So don't forget, extrusion has 3 varieties: monoradicular, polyradicular, and primary posterolateral. Let us look at polyradicular. Again, if you now look at the MRI diagram of this polyradicular, you will see that the extrusion is taking place at 3 levels. So this is not monoradicular anymore. This is polyradicular. So what do you think will be the clinical features? Well, the clinical feature is going to be like that of monoradicular, but it will be more severe. Why will it be more severe? Because the herniation is taking place at more than 1 segment. So it's going to be more severe features, just like we have in monoradicular. And their treatment is also it's not of good prognosis like when we have monoradicular. That's the chances of success of their treatment with physiotherapy is less than when we have monoradicular. All right. But the clinical features is the same thing, but it is more severe in polyradicular. And the third variety of this extrusion is the one called primary posterolateral. Primary posterolateral. Now, let me explain this primary posterolateral to you. Again, if you look at the MRI diagram, look at the disc, for God's sake. The disc has protruded and it has gone far lateral. It has pushing almost into the conus medullaris. It has pushed all the thicker material, is getting to the middle or almost covering the area where spinal cord should pass through. Can you see that from the red diagram? So because the disc has gone far lateral, that's part of the reason why it is called primary posterolateral. Do you understand? Now, how will it compress on the nerves? If you look at the lower diagram, the one on the left-hand side, you see that the disc is not going to compress the proximal part of the nerve root, that one that is labeled L4 root. Because the disc has gone far lateral, it's going to be compressing where? It's going to compressing the distal part of the nerve root. Are you with me, guys? And that distal part of the nerve root is the one that controls the leg pain. The proximal part of the nerve root that is not compressed is the one that is controlling the pain in the back. So what does that tell you? A patient with primary posterolateral extrusion, they will come to the clinic. They will say they don't have pain in their back. They will say the pain is in their leg. So there will be leg pain, no back pain, little or no back pain. And you as a physiotherapy, you get the MRI report, and the MRI report is saying they have disc prolapse at L4, L5. And you think because it's disc prolapse L4, L5, you should put the shortwave diathermy in their back. And the patient will be angry that why is this therapist putting shortwave on my back when I'm not feeling any pain in my back? I'm only feeling pain in my leg. Both of you are correct. You just need to explain to the patient that the pain is coming from the back, but because of the way that the pathology has happened, the disc has gone so far lateral that it's only affecting the segment of the nerve that supply the leg. It's no longer affecting the segment of the nerve that supply the back. Do you understand? So this is primary posterolateral extrusion. So how would this patient present it? The same way, like the last one that we discussed. But the only difference here will be that what? The patient will feel pain, more pain in their leg and little pain in their back, or no pain in their back, because the disc is herniating far lateral. And this is the kind of report that doctor will write to you. Take note of point C. They will say there is compression on the thicker material. When you read that from the radiological report, you know that the disc has gone too far lateral to compress on the thicker material. It's a massive disc prolapse that has gone posterolateral. But the clinical point of note for you is that this patient will present with what? leg pain and no back pain, or more leg pain and little back pain. All the neurological symptoms will be positive. All right. SLR will be positive. Myotome, dermatome will also be positive. All right. Don't forget, we are discussing nerve root pain, and we have discussed factors that could cause nerve root pain. We said disc prolapse with nerve root compromise, osteophyte with nerve root compromise, stenosis with nerve root compromise. You remember, we are still on nerve root pain. We are now discussing the disc prolapse in a greater detail. We are discussing the disc herniation in greater detail. And we have said it could either be a prolapse or protrusion, it could be extrusion, it could be what? Sequestration. We have seen two varieties of prolapse, which is posterocentral and posterolateral. Three varieties of extrusion: monoradicular, polyradicular, and primary posterolateral. So that when you see these patients, you'll be able to identify them. By the time we discuss manual therapy, you also know some of the importance of this classification that we are doing. Now, what about disc sequestration? That's the third category. What about disc sequestration? Now, on this slide, I wrote that disc sequestration occurs when part of the disc that herniated gets broken into fragments, and the fragments go to settle in another part of the spine. So the patient is no longer feeling the pain in one segment, but they are feeling the pain in too many segments. Then we said there is what? Sequestration. All right? So if you read the points, read bullet point number 2, you see the free fragment can migrate downward. So if the problem is taking place at L4, the free segment can now go to L5 or X1. It will even go upward. From L5, it can go upward and cause problem in the higher part. It can even migrate sideways, compressing of the thicker materials and the spinal cord. Do you understand? That's how we know sequestration. All right? And it can also trigger inflammatory reaction and immune reaction at the site of the pathology. So these are the three varieties of disc herniation: prolapse or protrusion, different from extrusion, different from sequestration. And this explains part of the causes of nerve root pain. All right, we are going to discuss other causes of nerve root pain. Let me take you back a little bit. 95% of cases are what? Non-specific, and we have discussed that. Less than 4% are what? Nerve root pain. We have just discussed that. The remaining less than 1%, we said, are due to what? Serious spinal pathology. That is where we are going now. We're going to come back to this nerve root pain towards the end of the presentation. Let's touch on this pain of serious spinal pathology, which is less than 1%. All right. So this is pain of serious spinal pathology. It accounts for less than 1% of all the complaints. Okay. And most patients that have this serious spinal pathology, they present with a set of clinical features that we call red flags. A set of clinical features. How do we identify them? They usually present with a set of clinical features that we call red flags, which we are going to discuss. But what are the major causes of this serious spinal pathology? It can be due to infection. So if there's infection in the area of the spine, vertebral osteomyelitis, tuberculosis, or other infection, it will be presented as serious spinal pathology. If there is cancer, or if there's fracture, all right, they will fall into the category of pain of serious spinal pathology. And less than 1% of this category come to our clinic today. A general guideline is for the physiotherapist or any other healthcare professional managing this patient to be able to look out for those signs that are called red flags. Anywhere you see red flags is an indication that serious spinal pathology is taking place. Serious spinal pathology are usually due to what? Infection, cancer, or trauma. All right. Let us look at these red flag signs. What are the signs of these red flags that we have been talking about? Generally, when a patient comes to your clinic and the patient is less than 18 years old, all right, maybe it's about 12 years old, and he tells you he's having back pain and the pain is going to the leg, that is abnormal. If a patient of 18 years old should have pain, maybe it should be due to muscle strain or tendon strain or ligament strain. We can understand that. Maybe the person is doing sports. But when a patient of 18 years, less than 20 years, having back pain and the pain is going to the leg, that is an indication that something serious can be taking place inside the body. It can be physiogenic pain. It can be due to the internal organ. It can be due to cancer. It can be due to infection. It could have been due to trauma. The same thing applies when somebody comes to your clinic for the first time, is experiencing pain for the first time, and the person is older than 50 years, 55 years, and is telling you that this is my first experience of pain, and the pain is going down to the leg. It is also a red flag. And we are going to discuss what we are going to do to them very shortly. Another thing you have to look out for as red flag, if a patient comes to your clinic and is coming with back pain, whether with or without leg pain, and the patient gives you a history that he was involved in a road traffic accident before the pain started, or he fall from a height, that's trauma. Both of those two cases are trauma. It will be treated as a red flag, and you need to order for special investigation, because there might even be fracture or crack fracture or incomplete fracture. So you don't rush into treating this category of pain. Now, when there is constant progressive non-mechanical pain, you know, we have talked about mechanical pain. If a patient is having non-mechanical pain, you ask the patient to do flexion, the pain is there, it's not changing, extension. You ask the patient to do side flexion, move in all the possible directions. None of those movements, you ask the patient to move in all the possible directions, and none of those movements is making the pain worse or easing the pain. That is not mechanical. And patients also report that the pain has been getting worse over time. Please, my brother, you need special investigation for that patient. That's a constant, progressive, non-mechanical pain. If a patient is presented with back pain in the thoracic region, there is upper back pain radiating to the anterior chest wall. You know, there are lots of vital organs there. The heart is there, the lung is there, and other sensitive organs are there. So it is a red flag. Upper back pain with thoracic pain is a red flag. Special investigation is needed. If a patient is presented with previous history of cancer, it's a red flag. Because the back pain the patient is bringing to your clinic might be due to metastasis from the cancer lodging on the vertebra or this musculoskeletal structure in the back. If a patient has an history of systemic steroid usage, he has been using steroid for a long time, it's a red flag, because the integrity of all the soft tissues could have been compromised. So you don't rush into doing manual therapy or physiotherapy for this group of patients without investigation. The same thing applies to a patient that have been on drug abuse medications and HIV patients, and the patient that have lost weight, not as a result of dieting or exercises. He just noticed that his weight is reducing. It might be due to tuberculosis or some sort of cancer that has not been diagnosed. So that is also a red flag. And finally, if a patient is presented with what we call cord sign, it is also a red flag. What are cord signs? Cord signs are signs of compression on cauda equina. When the cauda equina is compressed upon, there will be cord signs. So cord signs are signs of compression on cauda equina, and we are going to see that in a short while. How do we know when cauda equina is compressed upon? Or what could also be those mechanisms? What mechanism could lead to compression of cauda equina? I mean, we all know that spinal cord extend from C1 to L1. That's where spinal cord stop. From L2 down to the sacrum, there's no spinal cord again. What arose from the end of the spinal cord is what is called cauda equina. After L1, it's cauda equina that we have. So if there's any compression on this cauda equina, the patient will be presented with cord sign. All right. What are those mechanisms that could lead to compression of the cauda equina? It could be due to massive disc herniation. You remember when I told you if posterocentral herniation is massive, it can compress on both nerve roots on both sides. Patient will have pain going to both legs, or it can cause, if it happens beyond L1, if there's massive disc protrusion at L2, L3, L4, L5 downward, if it is posterocentral and it is massive, it can cause cauda equina sign. Metastasis, dislodge from cancer, infection, tumor, or trauma. These are the possible causes of compression on cauda equina. How are we going to know? What are the clinical features? There will be acute low back pain. Now, the pain can be radiating to both legs or one leg. You should have a good understanding of that. Because the cauda equina subserve both sides of the body. That's why we must watch out for a massive posterocentral disc protrusion. Then there will also be saddle anesthesia anytime cauda equina is compressed. You know what we call saddle anesthesia? Lack of sensation around the anus. The patient will tell you that he doesn't feel sensation whenever he sits down. It's as if the anus is numb. That is saddle anesthesia. There could be bladder incontinence, there could be bowel incontinence, or both of them. And the patient will definitely come down with sexual dysfunction. If it's a male, there will be weak erection or loss of penile erection, and there will be no ejaculation, because the sympathetic and parasympathetic nervous system that is responsible for erection and ejaculation are all embedded within that cauda equina area. So this combination of 5 signs are what we call cord sign. So they are cord sign. They are also sign of serious spinal condition, which we call red flags. All right. Let us now think about it. What should a physiotherapist do whenever we see 2 or 3 of these red flags or more? If you see one sign of red flags, maybe clinically, clinically, if you see one sign of red flag, if it is not cord sign, if you see any of the cord sign, please refer the patient for further investigation. If it is not a cord sign, you have seen all those 5 cord signs. If it is not a cord sign, if it's only one out of the other signs, you can commence your treatment. But if you see any of the cord sign, it's a trouble. Or if you see 2 or 3 signs that are not cord sign, you still have to refer. What I'm saying here is that it's not in every situation whereby you see a red flag that you refer, especially when it is not a cord sign. But generally, what must physiotherapy do? What must physiotherapy do when we notice a cord sign on our patient? Number 1, we should order for investigations. Some physiotherapy in some practice can order for investigation. Whereas some practice say, no, you are a physiotherapist, you cannot order. In that case, you will have to refer them to a specialist who can order, maybe a neurologist or an orthopedic surgeon. All right? So physiotherapist has to refer, physiotherapy has to order for investigation. If we do this, we might be able to help the patient. Early diagnosis will be made. And when early diagnoses are made, it will enhance the possibility of the patient's recovery from that pathology. Okay? All right. What if the patient is presented with cancer? You know, cancer is one of the possibility of red flag. If the patient is presented with cancer, it's a red flag. And the note we have here is that approximately 30% of patients with cancer will develop metastasis that can go to one segment of the spine or the other. You know, the most common case of cancer among women is the breast cancer. The most common case in men is prostate cancer. And lung cancer affects both male and female equally. So any of these cancer can dislodge metastasis to the spine. Now, when the metastasis get to the spine, the place they love to go mostly is the thoracic spine. The metastasis has highest affinity for the thoracic spine. That is why you must not treat any patient complaining of pain in the upper back with levity. Don't rush to do manual therapy when the pain is in the thoracic spine, because it might be due to metastasis, because metastasis has a very high affinity for the thoracic spine. 70% of cases of metastasis will go to the thoracic spine. It's only 20% that will go to the lumbar spine. So that's the preamble. But how do we know these patients with cancer? Their pain is usually non-mechanical, all right? But if cancer is in the ligaments, if cancer is in the bone, if cancer is in the muscle, you know, all those structure and mechanical structure, the patient can present with mechanical type of pain. But if the cancer is not within those structures, if it is in the conus medullaris, if it is inside the spinal cord, the pain will be non-mechanical. So we can see them, they will come with mechanical or non-mechanical pattern of pain. Another clinical feature of cancer pain is that their pain usually increases at night. Whereas patients that have mechanical pain, you know, their own pain eases at night. But in case of cancer, majority of the cancer cell, they are more active at night. And that is why patients with cancer pain will not be able to sleep. So if you have a history and your patient said he cannot sleep, the pain is usually more at night. That is when it suffered most. You know, it's most likely going to be a cancer pain, and it's a red flag. There might be sensory dysfunction and there might be autonomic dysfunction. And we know their line of management is usually towards chemotherapy, hormonal therapy, or radiation therapy. All right. Now other serious sources of back pain, apart from, we have clarified the non-specific, the nerve root pain, and pain of serious spinal pathology. Other possible sources of low back pain can be stenosis. All right. Stenosis is the narrowing of the foramen, either the vertebral foramen, which we call the lateral stenosis, or the central canal, where the spinal cord passes through, which is what we call central stenosis. When they are narrowed, the blood supply to the nerve will be impaired, and patients will come down with stenosis. Right. How can we differentiate a patient that is having pain in the back radiating to the leg? One is due to stenosis, the other one is not due to stenosis. How can we differentiate them? We should be able to differentiate them. But before I talk about this differentiation, let me first of all talk about what could cause the narrowing of the foramen. What are the things that could cause the narrowing of the foramen? They are just those factors that we have listed before. If there is disc herniation, if a disc shifts, the shifting can result into narrowing of the foramen. So disc herniation can cause stenosis. If there is osteophyte, and the osteophyte grows in the direction of the foramen, it can cause narrowing of the foramen. That is stenosis. Or if the whole vertebrae shifts one on top of the other, it can give rise to stenosis. So these are the possible causes of stenosis. Okay? Now, when stenosis happens, how do we know? How do we identify our patients? I'm sure you know. Some of us that have been managing them, you will know. Majority of these patients will tell you that whenever they stand up, their pain will come. And when they are walking, their pain will come. They cannot walk long distance. They have to sit down. And they will tell you that immediately they sit down, the pain disappeared. Why is it like that? Anytime they stand up, the spine go into extension. An extension causes more narrowing of the foramen. That's why they have more pain in standing and walking. And whenever we sit down or we lie down, our spine could go into flexion, and flexion relieves compression on the foramen. And that is why the patient feels better. Do you understand? Now, you know, I made a mention of a point the other time. I have once attended an interview, and one of the questions they asked me is that, how do you differentiate between a patient that have radiating pain? One is due to stenosis. The other one is just due to disc herniation, no stenosis. The answer is easy. When you see a patient that is having stenosis, the pain will be radiating. When you do a straight leg raising test, it will be negative. Why will straight leg raising test be negative? Because straight leg raising test is meant to diagnose compression at L4, L5, and X1 nerve roots. Straight leg raising test is not meant to diagnose stenosis. Do you understand? So if straight leg raising test is negative and there's radiating pain, and the patient is saying that anytime sit down or lie down, the pain eases off, then you can confirm stenosis. They like flexed position. They don't like extended spine position. I hope I made myself clear. And stenosis is also usually related to aging. You find stenosis in individuals approaching the age of 60 years or those that are above the age of 60 years. All right? So that's a potential source of pain also in the back. Another potential source of pain in the back is spondylolisthesis, what we call spondylolisthesis. The other word for spondylolisthesis is dislocation. Just think of dislocation in the peripheral joint. When one vertebra shifts on top of another, we said there is listhesis. All right? And this listhesis can take place anteriorly or posteriorly. When the listhesis occurs anteriorly, we call that anterolisthesis. And when it occurs posteriorly, we call that retrolisthesis. All right? And you know, when there's a shift of vertebrae like this, it can compress on nerve roots and cause nerve root pain. It can block or narrow the foramen and cause stenosis. All right? It can lead to intervertebral disc herniation. So it's a very serious source of pathology in the lower back. All right? But before we go into discussing the treatment, what are the classifications? Different classifications of listhesis that we have. It occurs in grade. Now, if you want to know the grade, if you look at this diagram that you have on this slide, you see that it's L5 that is moving forward on top of X1. All right, that is how we describe listhesis. We describe listhesis by making reference to the vertebrae above relative to the vertebrae below. So if I am to describe this listhesis now, I'm going to say that it's listhesis of L5 on X1. You will never say listhesis of X1 on L5. No. You describe it relative to the vertebrae above, moving on the vertebrae below. So it is listhesis of L5 on X1. Again, if I want to describe this listhesis you have on this diagram, I have to look at how is L5 moving. Is it moving anteriorly or posteriorly? Now you see this one is moving anteriorly. So I'm going to say it is what? Anterolisthesis. But if it is moving posteriorly, I will call it retrolisthesis. Again, if I want to describe this listhesis, I will divide the sacrum into 4 parts. If you describe the top, if you divide the top end of the sacrum into four equal parts, how far has the L5 moved? Has it moved to leave one part of those 4 parts? That will be first degree. Has it moved to leave 2 parts out of those 4 parts? That will be second degree or grade 2. So grade 1 spondylolisthesis is when the vertebrae above has moved by 25% or less on top of the vertebrae below. And grade 2 is when the vertebrae above has moved by between 25 to 50%. On the vertebrae below, grade 3 is 50 to 75%, and grade 4 is 76 to 100% when there is no more contact. That's grade 4 listhesis. And at that point, when the vertebrae above is no longer in contact with the vertebrae below, there's another term that is used to describe that. It is also called spondyloptosis. That is grade 5. When the vertebrae, when the slippage, when the separation between the vertebrae above and vertebrae below is more than 100 degrees, then we are going to call it spondyloptosis. And that is grade 5. Okay, that is spondyloptosis. Now, what is the other point of relevance to this, to all this? Grade 1 spondylolisthesis is usually treated conservatively. So if a patient has grade 1 listhesis, it will be referred to physiotherapist. All right? It's only when the listhesis is going to grade 2, grade 3, grade 4 that the surgery will have to be performed. And their line of management is almost similar to the same way we treat stenosis. This group of patients also, they don't like extension. So we use flexion-based treatment. We use traction, gentle traction, not too much of traction. And we use flexion-based treatment, and we use core stability. And you will test the flexibility of the muscle around their joint, the piriformis muscles, the iliopsoas muscles, and the rectus femoris. Any muscle that is tight, you will stretch it. The patient will get better. I think we'll talk about this when we get to management tomorrow. No, we're just going to look at the anatomy and the pathophysiology today. All right, so we are winding up. What are the treatment recommendations based on evidence and clinical prediction rules? I told you is tomorrow we are going to deal with management, but let's have a little insight into treatment recommendations. Well, at your own spare time before tomorrow, I want you to pay attention to this table. If you have a patient and you have carried out your subjective assessment and physical examination, and you find out that patient is having back pain and leg pain, but the leg pain, I'm discussing this manipulation segment. You know, there's manipulation segment, stabilization, extension, flexion, lateral shift, and traction as form of treatment. Let's discuss manipulation first. You have assessed your patient. The patient is having back pain and leg pain, but the pain in the leg is not going beyond the knee joint. Okay, and the symptoms is less than 16 days. And the patient is not having so much fear of movement. The fear avoidance belief score is less than 19. And there is hypomobility. You find out that one segment of the lumbar or lumbosacral is not moving the way it should move. Then manipulation is the best choice of treatment. All right? I am going to go to extension, the third one. Leave stabilization alone first. I'm going to extension. For some of us, or some of you that are training Mackenzie, and if we have time, I can also introduce the Mackenzie PowerPoint slide tomorrow. You assess your patient, you find out that extension relieves the pain of your patient. Do you understand? In other words, extension movement centralizes the pain of your patient. All right? And when you ask the patient to do flexion, the pain is increasing. That means flexion is peripheralizing the pain. You know that time when you do spinal range of movement, you finish your normal spinal range of movement, you now ask the patient to do 6 extension. 1, 2, and by the time he did the 6th one, you ask him how is he feeling. Oh, he said the pain has relieved. You will treat that patient with extension-based exercises. That's the recommendation. What are these extension-based exercises? Like pelvic bridging with leg loading, like cat and bird and dog exercises. I will show you some diagram of those tomorrow, if not today. But if you observe, on the other hand, that your patient is responding positively to repeated flexion. It's repeated flexion that is making the patient pain to feel better. When you ask him to do repeated extension, the pain is peripheralizing or aggravating. You will use flexion-based exercise to treat the patient. What if you now observe that both repeated extension is peripheralizing the pain, repeated flexion is peripheralizing the pain? Which movement will you now use? You will simply use stabilization exercises. Do you understand? You will use stabilization exercises and traction. That patient will get better. This is the way I train my interns so that they can hit the road running. All right? Once they do repeated movement tests, extension is good, use extension base. If flexion is good, use flexion base. What are the flexion based exercises? Knee to chest, single knee to chest, double knee to chest, lumbar rotation, lumbar flexion in sitting, lumbar flexion in standing. All this one will make the patient well. But what if extension is peripheralizing the pain, flexion is peripheralizing the pain? Then you go and use stabilization exercises and traction. All right? So you can see in the first column, the group of treatments. In the second column, you can see the clinical features you have to look out for before you choose the treatment. All right? And then in the third column, you can see further description of the treatment section. Okay? It's almost 10:30 now. I will not start the next one because we'll not be able to finish before 11. And I know a lot of people want to fly into their bed now. This is quite an unusual class. So it will make sense if we stop the presentation this evening at this point while we continue with treatment option and look at some other factors in tomorrow's presentation. Once again, I salute you and I really appreciate you for joining up with me to teach this course at this particular point in time. I'm sure you know that I don't joke with my work. It's just the prevailing circumstances that box us into this kind of situation. But we will do our best. We will do our best. I will describe the treatment tomorrow. I must arrange with the provider, with the Ray physio, to give us a time in the afternoon that will be convenient for all of us, even if you are going to give me one of your weekend in the afternoon, whereby I will be able to show you. I will be carrying out the treatment video-based, and you will have the opportunity to see it. Thank you very much. I am very grateful for your comments. Thank you, and see you tomorrow. Thank you, everyone. Yes, Minat, thank you. Thank you so much. Thank you, everybody.
Thank you,
for
sir.
your comments. Thank you.
Thank you so much.
Thank you.
Thank you,
Thank
sir.
you.
Thank you, sir.
Thank you, Dr. Rosemary. Thank you, Adeniro, my daughter, Temilolu
Thank
Adeniro.
you,
Thank
sir.
you very much. And thank you,
Thank you,
everyone.
sir.
Thank you, everyone.
Yes, sir.
Thank
Yeah,
you.
we really appreciate you. It's a
Thank
very
you, Dr.
interesting
G.
lecture.
Thank you very much.
You, sir.
Looking
Thank
forward
you,
to seeing
sir.
you tomorrow. Please
Thank
have
you,
a
sir.
nice rest and see you tomorrow.
Askiro, come and pack all these things here. I'll finish my class. Let me go and pray. So come on, Park. I'll still need this thing for the drug. No, this one is small. I'll come take another one.